So I'll go ahead and get started. My name is Heather Saffel. I was the fellow representative on our subcommittee for the Fellows Lecture online series, and now I'm currently faculty with the Notre Dame Fellowship in South Bend. Today we are going to hear a talk on Sports Psych 101 from Vicki Nelson, MD, PhD. And so she is currently in South Carolina, the Greenville area, working with Prisma Health at the Stedman Hawkins Clinic of the Carolinas. She's the research director there for family medicine and sports medicine, active in mental health, concussion, and she's also faculty as part of the residency and fellowship, and does coverage for local high schools as well as the two colleges in the area, Furman and North Greenville. So I will go ahead and let her get started after I go through a few quick things first. So let me click to the next slide. Most of you have already joined in on these lectures before. So this is an adjunct to fellowship programs across the country to help with additional education given by experienced AMSSM members, sometimes guest lecturers, and to assist with CAQ exam preparation. Please feel free to submit any questions in the chat, or feel free to unmute yourself and ask a question if you feel comfortable doing that. And I will go ahead and let her get started. So let me stop sharing. Thank you for joining us, Dr. Nelson. Go ahead and get started.
All right, thank you. So like you said, we're going to try and jump into sports psych, and we kind of labeled this Sports Psych 101, and are really taking a big picture, very distant view of what is psychiatry, psychology, and kind of mental health as it affects athletes. So here we go. Really broadly, we're going to go through some kind of general mental health concerns that are just very common in the population, and talk a little bit about special comments or prevalence in athletes, cover a couple of things that are particularly common in athletes in sport, and then a little bit of talk about how do we actually address, manage, treat, kind of think about mental health, the psychology and care of athletes. And for me, a lot of this we're going to address from kind of the thought process of team physician, just because that's, I think, where it makes the most sense and you have the biggest impact. But in general, if you don't listen to anything else and you've got to run back off to clinic, general takeaways right up front. So mental health concerns in general are pretty comparable in athletes and age-matched peers. Part of why this is really important, particularly in scholastic athletes, high school and college age, teen, adolescents, early, young adults have a very high prevalence of mental health concerns. And for a lot of the concerns that we're going to talk about, that's typically when things initially present or when onset starts. So even if we don't necessarily think of an athlete as a special entity and just thinking about them as their non-athletic peers, this is still a big concern in an area that we need to be comfortable with and prepared to address in the athletes when it presents. So for those people that are serving kind of in a primary care role, particularly, I said, team physicians and things like that, but even in a primary care clinic, being prepared to deal with the mental health is really important. It has a big impact on performance, but really just the well-being of the athlete, kind of as a person and their enjoyment of sport and life in general. So trying to be as comfortable as you can in managing that, and acknowledging where your comfort and your boundaries are if you need to kind of move that forward and move that athlete on to somebody else who's more comfortable managing things in the long term. There we go. So like I said, I really think about this mostly from the aspect of a team physician, and that's really where we're going to look at this moving forward with that kind of team care lens. Outside of your role as a team physician, there's not a lot really out there in the literature or research about what the role of a sports physician is. So for somebody who's seeing athletes or just general people in a kind of non-surgical orthopedic practice, your involvement in mental health and psychiatry and dealing with some of those issues around injury is probably smaller, but still, again, kind of being aware that some of these things present, particularly in the context of injuries and time loss, and particularly end of career injuries and things like that, that may just need a little bit more special attention, can just be helpful to be aware of and alert to. But the big thing here is that the role of the physician and how far you're going to take what you do with mental health and how involved you're going to be really just depends on where you are and where you're practicing. If you are, like I said, based with a team, or you're in student health, or you're in a primary care office, you may be somebody who's managing this for a longer term and doing a fair bit of day-to-day management of mental health with athletes. So step one, I think, is prevention, right? And part of that is really just starting to have the conversation. And really over the last decade or a couple of decades even, that conversation's gotten bigger and louder. The NCAA has done a lot recently to try and address mental health. And I'll refer to the mental health best practices several times throughout the presentation. They actually have done a really great job of putting together resources for campus professionals, staff, coaches, and of course team physicians. So one of those resources that they threw together is not really the right term, but put together for us to use is this interdisciplinary team planner, which is really a step-by-step approach to think about how do you organize a mental health program really from beginning to end, and helps address a lot of those aspects of prevention and really just preparedness. So everything is either from funding, so even once you identify the needs that you need for your program, how are you going to support that, whether that's grant money, whether that's institutional money, volunteer time, developing policies to address mental health needs, things that include prevention to response and follow-up, that institutional assessment of what you have available. So is this a place where you have good counseling service available? Is there no counseling available? Is there student health that offers mental health? Is this something that you need to start from scratch? Are you looking for community providers? Where is that kind of support going to come from? What's the buy-in from your staff? What's the buy-in from the athletic department as a whole, from your coaches, from athletes that are already there? And trying to identify what some of those obstacles or battles are going to be in implementing and addressing some of the mental health. Education, clearly a big one. Screening, we're going to talk a fair bit about in just a second. Protocols for referrals, like I said, identifying where your resources are and identifying honestly what your areas of weakness are when you're starting to address mental health and where do you need help. The intervention plans and action plans, and just a clear list of treatment options and contacts. And the activism, I think, is a great one to include in there. And whether that really belongs at the end of the list or not, we could debate, but a lot of that intervention and outreach and reducing stigma and things like that is really important as we continue to address mental health in athletes. So prevention, I said, really getting to know what your program needs is step one, and it seems really straightforward, but certainly is a lot more complicated than it sounds. But really taking the time to talk to all of those people. And if you need to, using anonymous forms, anonymous surveys and things like that to get honest feedback from athletes, coaches, staff about what's going on and what the needs are and what struggles people have faced in the past. In my experience, athletic trainers have been fabulous as a resource of really identifying where obstacles have popped up in care, whether that's referral, whether that's finding counseling, whether that's medication. They tend to be very in touch with the pulse of the campus and feedback from the athletes. So they tend to have a good relationship with a lot of the athletes and be that first line of communication. So trusting them and relying on a lot of that feedback has been really helpful. Building the team, and I'll come back to the team over and over and over again. Making sure you've got a good core group of physicians. And if you're not somebody who's comfortable with mental health, making sure you've got somebody that is, whether that's, you know, somebody in the primary care spectrum, whether that's a psychiatrist, a psychologist, you know, knowing who your referral people are, knowing where your sources of counseling are going to be, if that's on campus or not, knowing the role of your athletic trainers and what their comfort level is with addressing a lot of the mental health problems. It's really essential to know who the players are when something comes up. Being clear on how problems need to be addressed when they present, and that goes back to some of that planning and protocol. So in general, takeaways, make sure you have an appropriate environment. So a lot of this, you know, maybe isn't the right thing to just drop into the training room visit that you're having on, you know, a weekly basis and start a confidential conversation in the middle of the training room. So really planning ahead and figuring out where that conversation needs to be so that you can get the information and provide the support that you need to, making sure that you're clear, calm, and concise. Avoiding judgment in any of your responses, your reactions, you know, your facial expressions, things like that. Really just providing support and making the athlete feel like they're in a place where they can share what they need to share. Having a plan for follow-up. At the end of the conversation, you should never just leave the conversation and walk away, whether that's, you know, checking in with you, checking in with the trainer, checking in with counseling. Knowing what comes next is essential. Giving that athlete some control can be really helpful, especially when we're in that spectrum of, you know, things like depression, anxiety, eating disorders, disordered eating. Giving the athlete control and not taking that away can make a big difference, not just to their sense of, you know, coping and that sort of stuff, but in a lot of those situations, you may be kind of modifying their participation in sport or kind of taking away that sense of control and identity. So being able to replace that a little bit in giving them ownership over, you know, their health and their wellness can be helpful. So again, if you're not comfortable, find someone who is comfortable in the long term, and really just, you know, offer support initially, and, you know, make sure that they feel supported and confident that you're going to be able to find somebody who is really that long-term person if that's not you. So screening, we've talked a lot about kind of in the literature and research around mental health has really been focused a lot on that early side of how do we identify these things and what are the right tools and what's the best approach. And again, the NCAA has a lot of suggestions in there, and I think the big takeaway is that this really should be happening. And their suggestion is to include that as part of the PPE. And, you know, how you do that as part of the PPE, I think really depends on what your PPEs look like. So definitely customizable to your particular program. But, you know, consideration even just from what screening instruments do you use. There's a handful that are offered in the mental health best practices, and it's by no means a comprehensive list or, you know, a reflection of what everybody is kind of doing as standard of care, but simply a starting place and some suggestions for you to kind of start the conversation, I think, of what to use. And even there, you can kind of see two different approaches. That NATA 9-question kind of consensus recommendation for questions is a pretty broad kind of general screening instrument for mental health, including some questions about things like depression and anxiety and sleep and kind of general well-being and happiness. They also offer that kind of alternative of disorder-specific tools that are designed exclusively to look for really one mental health disorder. So just to screen for depression, or just to screen for anxiety, or just disordered eating. The challenge with some of those is that, you know, they obviously only screen for one disorder. So if you're going into your PPE saying we're going to kind of broadly screen for multiple mental health problems, you know, that list of questions kind of multiplies really quickly, becomes a little bit unwieldy. And, you know, the more questions you offer, of course, the less happy your athletes are going to be as they're getting to page 4 and 5 of filling out questionnaires. So really being thoughtful about the right combination and what you're deciding to look for. Fairly recently, the IOC put out this SMART tool, which is just, you know, essentially a short, broad mental health assessment, and was, you know, initially just kind of looked at in elite athletes. and published essentially, kind of saying, hey, this is intended for elite athletes. And I think there's more coming on that in the future. It looks like a pretty promising tool to kind of identify essentially at-risk athletes that probably need some, of that follow-up screening with more disorder-specific tools. But probably something that we're going to see more and more about in upcoming years. All right, so essentially, screen for mental health concerns in the PPE. Think about how you're going to do that and which tests you want to use, but definitely adaptable to a particular setting. Make sure you have an adequate follow-up, and that, just like your USPSTF recommendations for mental health screening, you've got to have a follow-up plan if you're going to screen. And then make sure that that plan is completely organized, completely in place, and you know what each of those follow-up steps is going to be. So what are you screening for? We talked about which tests, who's actually doing the screening can sometimes make a big difference, whether that's athletic trainers, whether that's anonymous kind of paper surveys that you review later, whether that's done at the PPE with the physician. Sometimes that's a counseling office. Sometimes it's done in student health and that sort of place. The when and where, so with the PPE sometimes makes sense and sometimes doesn't, depending on what your PPE looks like. And we said strategies for follow-up. Strategy is really to address those who decline care or decline further follow-up, and knowing what that looks like and how you're going to manage those. And then, of course, that same thing as strategies for referral and where things go when you feel like things need to be escalated kind of out of your scope. So briefly, as an example there, things we kind of talked about, maybe you decide to use this broad screening tool, possibly the NATA suggested questions, which is relatively brief with 9 questions. So you're probably not going to get too much, question fatigue. Maybe your athletic trainers do that, going into the PPE. Those who have a positive screen get followed up with the team physician, and your team physician feels reasonably comfortable deciding, looking at those that maybe we need to do follow-up questions for, depression or anxiety or insomnia. You've got your team physician in place to follow up, and then you've kind of identified either your campus counseling center, which is going to be really helpful for things that don't necessarily need medication, but just some follow-up, and a psychologist, and then a community psychiatrist that you think is going to be helpful more with long-term medical management or things that are getting a little bit more complex. So if we have time, that's certainly something we can kind of talk more about, different examples and strategies, but just one out there to think about. So moving, I said, kind of quickly along here, I'm going to touch on to some common issues and just their presentations or prevalence in athletes. So depression, again, quite common and really just common in high school and college age students in general. So something that as a team physician, you're going to see a lot of in that population. In general, the reports will give you about 20%, 1 in 4, 1 in 5 college athletes, which is very, very similar to general college surveys, in teens and young adults. That you're still typically seeing that 1 in 4, 1 in 5 that are reporting symptoms. So of course, it relies on a self-report. So they're taking all of this with a grain of salt, which is true for most of the mental health statistics that you're going to see out there. In general, it's more prevalent in females, and again, whether that's a manifestation of self-reporting or if that's a true physiologic prevalence, hard to know. It does seem to be a little bit more common in athletes participating in individual sports rather than team sports. Potentially, something related to the support of the team and those kind of peer supports. Teen and young adults, so it's certainly a risk factor, and that prevalence there is just really high. Those nearing the end of career, those with injury, and those suffering poor performance or a lot of performance pressure may have a higher incidence of depression or higher depressive symptoms. And some of the thought there just being that increased stressors bringing out increased symptomatology, and the athlete's ability to cope just isn't quite what it used to be, and they need a little bit more intervention and support. So in general, management is basically the same as the rest of the population. So for the people that are comfortable managing depression, generally in their clinic, it's not hugely different with the athletes. It's certainly helpful to have somebody around that can have conversations with them that understands kind of their community and their expectations, and help bridge that with, coaching and staff and that sort of stuff as needed. Again, making sure you've got that appropriate team in place. If you're somebody who's not on campus or not seeing the athletes, on a daily basis, talking to the people that do. And again, whether athletic trainers, coaches, support staff, whoever that athlete kind of feels comfortable identifying as part of their care team and support, really helpful to identify, bad days or, bad trends where an athlete's really just struggling or things are moving in the wrong direction. Always being sure to assess suicidality, and we'll talk a little bit more about that in a second. Psychology and counseling, really helpful in depression, just like it is in the general population. Cognitive behavioral therapy, really helpful. General mindfulness seems to be helpful and is getting more and more attention in the literature, both for depression and just for sports performance. So, maybe one way to get a little bit of buy-in from athletes as well. From a pharmacologic standpoint, the mainstay really seems to be SSRIs, which of course is true in the general population as well. Fluoxetine seems to be the most studied, kind of most accepted in athletes as far as, a favorable side effect profile. Bupropion actually, may be beneficial from kind of a stimulating kind of side effect. The challenge there is it's currently on the WADA monitoring list, so may not be the ideal choice if you've got somebody kind of at that elite level, and definitely something to keep an eye on. SNRIs, tricyclics, really not something that's gotten a lot of attention or research in athletics at this point, and not preferred, but the theory there is that the side effects probably not as beneficial or well tolerated in athletes as some of the other options. So suicide, again, probably pretty comparable to non-athletic peers. But again, we're talking about a pretty high risk population. And I think, especially as team physicians and part of their athletic team, a lot of times you get to build a pretty good relationship with a lot of these students and kind of serve as that front line of prevention and intervention. So being comfortable with that and, really knowing that your team on campus is comfortable intervening if they have concerns and have an emergency action plan is really helpful. So same as peers, suicide death is higher in male athletes, suicide attempts are higher in female athletes. Definitely something to kind of keep your radar up for. Social inclusion and pressures, whether that's performance, academic, anything just coming from peers as well, can certainly increase risk. Bullying and hazing, not necessarily unique to athletics, but is very common in athletics. Academics, achievement, failures to succeed, that body image, identity, family, life stress, clearly all things that are part of the athletic experience. Illness and injury and substance use, performance enhancing drugs can increase that as well. Of course, the management there is prevention. Prevent and intervene. So the faster you can identify something, the more likely you are to successfully prevent a suicide attempt or suicide death. Treating underlying conditions. So if this is somebody that you've managed to identify, a substance use disorder, depression, anxiety, really anything that's kind of affecting their ability to cope, needs to be addressed. Removing any threats or access to threats to self-harm, making sure you have an emergency action plan in place. We're going to talk about that over and over and over, and you're going to hear that emergency action plan phrase. And again, making sure that the staff and trainers are empowered and comfortable to respond. So whoever that front line is that's in front of the athletes on a daily basis, really needs to be able and be comfortable pulling the trigger and saying, hey, we need to do this action plan, I'm concerned. So you really need to, one, take the responsibility of making sure that your support, your staff, your trainers are all comfortable doing that and are educated appropriately, and really empower them to do it and give them the responsibility and authority to not hesitate if they do have a concern. So again, moving forward, anxiety, just like depression, the story is very similar in that we're really comparing to the peer population. It's about the same, but quite prevalent. So looking at college students, about 1 in 3 We'll experience anxiety, which is a lot, right? So, even just 1 in 3 athletes, it's a lot of athletes that we're talking about on a national scale. And again, it really just tends to be part of their age group and their peer group, that this is just a problem that tends to present here in adolescence and young adulthood. Really important from the sports standpoint to try and differentiate generalized anxiety disorder, or generalized anxiety symptoms from performance anxiety or anxiety related to sport itself. Really from the standpoint of management. So, anxiety that really just surrounds their sport participation or their sport performance is not going to be well managed by pharmacotherapy. So that's something that really having a good relationship with a sports psychologist or a good relationship with somebody in your counseling center who understands kind of the pressures and the unique needs of an athlete is really helpful. Part of that is the medications that are available kind of on an as needed basis for kind of situational anxiety are not great from a sports standpoint. So, the side effects of things like beta blockers and benzodiazepines are not going to help sports performance, which is probably not what you need if you're already having anxiety about your participation or performance in sports. Decreasing blood pressure, sedation, muscle relaxation, decreased response time, things like that is just not going to help. But additionally, they may very well be banned depending on what level your athletes are participating in. And that's certainly not something that you want to get yourself into or set the athlete up for. So in general, make sure you find a good sports psychologist and develop that relationship to intervene if that's something that's coming up. Generalized anxiety, again, the cognitive behavioral therapy, your psychologist and sports psychologist can be really helpful. So those cognitive interventions can make a big impact. But the pharmacotherapy, the medications are still helpful. And again, just like the general population, your SSRIs, and then buspirone, plus minus the SSRI, really your first line and your mainstay. The short acting, again, benzos, beta blockers, not really what you're looking for here. All right. So I said, we're flying through and we're trying to stay mile high, but thinking about a couple of unique issues that actually are more prevalent in athletes. Like I said, most things are not. Most mental health concerns you're going to find are about the same in athletes and peers, with a few notable exceptions. And one of those, of course, is concussion. We know that concussion is extremely common in athletes. The millions of athletes a year are experiencing this. And, we're not going to get into the management of necessarily concussion and, all of that as we go, but just to kind of increase awareness that, one, pre-existing mental health conditions definitely complicate the picture. Even just from a standpoint of it taking longer for symptoms to resolve. Those with pre-existing conditions are at higher risk just of having, a prolonged recovery, post-concussion symptoms, or even just lasting symptoms. But even those without pre-existing mental health conditions, it's very common to report some degree of mental health symptoms kind of during or following that concussion. Just thinking about your symptom checklist, things like sadness, anxiety, irritability, personality change, all things that are fairly commonly reported. And the hope being that, as your concussion resolves and the rest of your symptoms resolve, those all go back to normal and are something that we can kind of put behind us and move forward. But that's not necessarily the case, particularly in those with pre-existing conditions, that may flare or uncover something that, again, the athlete was doing a pretty good job coping with previously, and now they're just really not able to kind of manage that on their own and need a little bit more support, whether that's from a counseling or psychology standpoint or from a medication standpoint, both in the thoughts of, depression, anxiety, sleep is huge, PTSD, and it's certainly, less so in the sports population than, some of your, car accidents or things like that, but definitely a consideration. It can affect how you're thinking about sport or how you feel about returning to sport if you've had a pretty significant trauma. So, really thinking about, is it differentiating those symptoms? So the kind of mood and affective symptoms related to concussion versus separating that out from underlying mental health concerns or an underlying diagnosis be really difficult, and really might not be something that you're able to do kind of in that acute setting. But especially as something as, the concussion resolves, making sure that you're paying attention and, aware and alert that that's something that you need to be aware of. Particularly in the setting of things that persist, making sure that you've got good support, thinking about, is this, like I said, that underlying diagnosis that we just didn't know about before, and making sure that those needs are then addressed. And the whys of all of this, I think, is a little bit harder. And I suspect that in the research world, you're going to see a little bit more of the why as things go forward. And some of that, is this just the pathophysiology? And obviously the concussion is an injury to the brain. Mental health kind of manifests, of course, through the brain and the brain physiology. And is there something that has disrupted neuroregulation, neurosignaling, neurohormones, all of the levels of just brain physiology that just aren't quite functioning normal anymore, and may take longer to go back to normal than we really think in the context of concussion. But again, is this something that just evolves due to all of the stressors and experiences that come along with concussion? So you've taken, essentially a social, generally high achieving, athletic person, and they've been removed from sport, they've been removed from school, they've lost a lot of their peer connections and peer supports as part of this experience. And if the concussion takes a long time to recover, just that return to life and the return to school, the return to sport, the stress and the pressures and the expectations and all of that, you can just feel kind of building on top of the usual pressures that the athlete has to face, and their ability to cope with that and deal with that and everything else, may just need, again, more support. The other is that the medications used in concussion can cause some of these things, right? So thinking about stimulant medications that can be used for concussion, thinking about things like Topamax with sedation and fatigue and your tricyclics, and the spectrum of potential side effects in your treating medications are definitely something to keep in mind, and getting people back off of medications as soon as you can, just to make sure that it's not something that is caused by your medical care. So really, I guess I want people to at least be alert in the context of concussion, because I feel like we don't necessarily jump to consideration of mental health management during the concussion and that exacerbation of symptoms. So something that I'd really like to see everybody keep kind of at the forefront when they're thinking about recovery. All right, disordered eating, compulsive exercise. So this is, certainly something in our sports world that could, have a 3-hour lecture, unto itself. So we're really skimming the surface. Again, this is something particularly prevalent in our athletic populations, and something that you do hear a lot about in our primary care sports community. Depending on where you look, the prevalence varies, but is notably high, particularly in kind of collegiate and elite athletes. Females, that 2/3 plus, you'll see those numbers kind of thrown around as far as prevalence of disordered eating. And I think where we lose some of the attention, or what underappreciated, is really just how prevalent it is in male athletes as well. We spend a lot of time talking about that female athlete triad, and 1 in 3 male athletes is a lot. And I think they just don't quite get as much attention as their female counterparts in this context. And there's, the behaviors related with bulimia nervosa as opposed to anorexia nervosa are a little bit more common. But either way, the numbers there are just, staggering and a little bit terrifying if you're somebody who works in this population. Aside from, some of the medical issues that we're going to talk about, the risk of musculoskeletal injury is much higher in athletes with disordered eating and compulsive exercise. Certainly more common in aesthetic sports, so those where you're kind of judged on appearance, so gymnastics, bodybuilding, that sort of stuff. And then weight-based or weight-classed sports, so things like wrestling, rowing, martial arts, tends to be a little bit more common based on the pressures of the sport itself. So you'll see lots of names, and ultimately what this comes down to from our sports side is we're worried about a relative energy deficiency or nutritional deficiency, low energy availability, ultimately saying that that caloric balance, calories in and calories out, is completely out of whack. You'll see, like I said, the female athlete triad or male athlete triad talked about quite a bit, and we'll touch on that in just a second. Screening is super important. So definitely with your PPEs, I'd encourage you to think about at least including a couple of questions in the context of disordered eating, or making sure that at the very least you're kind of doing a BMI screen and that sort of stuff. And while it's not perfect, it's certainly better than nothing. The list here is by no means comprehensive, but intended to at least give you a handful that have been examined in athletes or examined in kind of age-appropriate peer groups. So you've got lots of choices, and again, it kind of varies in length and focus and what each of these tests is really looking for. So trying to find one that you're comfortable with and that your screening team is comfortable with is really a great place to start. I don't think we're at a point in kind of our understanding of sports mental health and to really pick one of these over another. So I think it's kind of up to you kind of as dealer's choice, but pick something, pick anything, pick something, please screen. Keeping in mind that screening is not a diagnosis. And of course, this is true for everything. But I think particularly difficult when we talk about disordered eating and we talk about eating disorders. Eating disorders are a DSM diagnosis and certainly not something you're going to pick up on a screening test. Disordered eating, is behavior, and it's certainly something that you can pick up even in just a conversation with an athlete and raise your concerns for, eating disorder, something that needs further follow-up. So this is kind of that classic, athlete triad diagram from the consensus statement from 2014. And, again, really just making sure that if you have concern for one component of the triad or one component of disordered eating and compulsive exercise, you're really looking at the other end of that spectrum as well and looking at those other components. They do tend to go hand in hand, but be more prevalent. When you find one, you're more likely to start finding some of the other things pop up as well. So when you've got concern, making sure that you're following up your screening with additional assessments, additional referrals, additional interviews. And again, going back to that initial kind of situation of making sure that's happening in the appropriate environment with the appropriate person at the appropriate time and appropriate intervals, and that you've got a good kind of support network and net to kind of catch people that are slipping through that first line even. For those you do identify, as I said, thinking about lab monitoring, an ECG, bone mineral density, pretty routine, particularly in people that you really think are getting towards that eating disorder side of things, and less of starting to display some mild disordered eating behaviors. The additional psychiatric evaluation in the context of disordered eating and concern about eating disorder is somewhere that even dealing with a lot of mental health and a lot of disordered eating is somewhere that I tend to pull the trigger a little bit faster in getting psychiatric involvement and somebody who's just really specialized in disordered eating, as it can be a very different kind of counseling approach and nutrition approach than a lot of the other mental health disorders. So finding somebody who's got a lot of experience in the area is going to be really helpful. Again, making sure you're considering that DSM diagnosis, but making sure you're considering other diagnoses as well. So the disordered eating and kind of unhealthy eating behaviors can present as part of depression. They can present as part of anxiety. They can present really as a manifestation of several kind of mental health disorders. So not necessarily jumping straight from disordered eating to eating disorder, but kind of underlying and thinking about that root cause to make sure you're addressing things in the way that you need to. For that, again, the multidisciplinary team, huge. Having the buy-in of your coach and your strength staff is really important, particularly if you are in one of those areas where you've got an aesthetic or a weight-based sport where there may be some pressure coming from their coach or strength or kind of even the athletic department or scholarship or whatever else to really maintain a particular weight or a particular appearance. And then, of course, you'll see that on both ends of the spectrum, though. Here we're clearly talking about the lower end of the BMIs, but you'll see that on the upper end as well. Exercise and sport restriction is really the mainstay of starting to get things under control. And unfortunately, in our sickest athletes, that a lot of times will rely on exercise as part of their coping strategies. Pulling that away can be really difficult, and kind of set things back as well. So making sure that you're placing other strategies and providing support as you're doing that is really important. And again, you're really considering those metabolic and cardiac abnormalities. Those labs are going to be helpful, taking a good history. And then using, as best you can, an objective tool to help you make a decision about the safety of participation. And what's there on the right-hand side is the cumulative risk assessment for the female athlete triad, again, from that consensus statement. And really just a straightforward way to kind of say, is this person safe or not to keep participating? And as you can see, it's fairly straightforward to kind of go in and look at that column and say, all right, I've got somebody with a low BMI. Is that greater than 18.5? Maybe that's a 0. I'm not so concerned. Is that okay? I know it's 17. I'm way over on the other end of the column and I'm getting more points. But this is something, if they've got 1 point, is a pretty low cutoff, but 0 to 1 is generally the safe place for participation. Over 6, you're definitely not participating, and that in between is kind of in between. And you've got to use a little bit more, art of medical decision making and that sort of stuff, and decide how comfortable you are with what they're able to do, and kind of tweak some of that limited participation. But particularly acutely, having a 0 tolerance and just, no sports, no exercise while things get under control can be helpful. All right. Hazing and bullying. I'm not going to get into too much depth, but this is a kind of pet topic for me. It's one that's, been close, in my pre-sports life, working in student health and fraternity and sorority life. So moving into athletics, it's something that kind of stayed close to home. And I think the numbers and the statistics are even more depressing in athletics than they were in fraternities and sororities, which was kind of surprising to me. If you go into the sorority fraternity world, hazing is in the forefront of basically every meeting that you go to, every conversation. And in athletics, it's really not something that gets a lot of airtime. There has been more over the last couple of years, and you can see up there on top the hazing prevention in college athletes from the NCAA, which has come out recently. But the numbers are all over the place. But upwards of 80% of NCAA athletes report experiencing hazing, which is again a huge number. The more challenging to me, I think, is that number of 12% identify it as hazing. So if you ask people about what experiences they've experienced, they'll acknowledge that they've experienced these things that have been categorized as hazing, but most of them don't really associate that with the word or the negative connotations of hazing or bullying. And the vast majority are not going to report this. A lot of them will even tell you it was a great positive experience. They would love to do it again, and they feel closer to their team than ever before. And I think it's those experiences and that kind of acceptance in our sports culture that makes it difficult. But there are a lot of negative aspects to this as well, and a lot of athletes that really struggle to cope with this, or that have transferred schools or just quit sports altogether because of those kind of hazing and initiation experiences. So it is a big problem. It's very prevalent. Again, really hard to know just how common this is or what the impact really is, because reporting. So really trusting people to report, and to report honestly, is really difficult. But it does seem like those who experience hazing or experience bullying as part of their athletic experience have increased anxiety, increased depression, and occasionally even PTSD, lots of academic difficulties. You'll see, stories on both ends, the people, like I said, the team building, and the people who love it and it was the greatest thing they've ever done, and the team estrangement, the people that never feel like they're able to kind of count on or rely on their team members anymore. Particularly common, or particularly at risk, if you've got a team that's kind of built on this power hierarchy, or those where your senior athletes are clearly more important, or have more prowess than your freshmen and that sort of stuff. The legal implications of hazing are enormous. Most states have anti-hazing legislature that make it absolutely illegal to bully and haze anyone but a peer. Prevention, again, is really the mainstay, that we can't do a whole lot in hindsight other than provide support to the athletes that reach out to us, which may be fewer and farther between than we would hope. But really staying alert and kind of trying to watch what the culture is, on your teams and in your communities. The support from coaches and staff and athletic directors to really build a culture where this is just not accepted is essential. We're not going to really make progress until this is something that as a community we decide just isn't acceptable. So like I said, build a culture that prevents hazing, avoid hierarchy. Is that hierarchy is really a big proponent to increasing prevalence. Finding a way to promote team building and initiation activities that are really positive. Certainly things that aren't putting athletes at risk, which is a worry with a lot of the hazing and bullying behaviors that happen. But I think if we want people to avoid doing these things that have become as a part of culture and are really seen as a great bonding experience, you've got to find a way to replace that with something else. Peer-led programs actually seem to be the most effective. So, in a lot of ways, us coming in as physicians or, athletic directors, staff coaches, really, it's not who the athletes want to hear from. And finding, those peer champions to lead programs is going to be the most helpful. Is it clear expectations from leadership, from your athletic directors, from your staff, from your coach, from your campus, university presidents? It's really got to be a top-down, but this is just not okay. The medical team, I think, we're there really as a safe space. And I like to hope that, in the campuses that I work with, my athletic trainers, I love to death, and they do a great job of building those relationships with the athletes. And I truly believe, and I hope that that's true, that, they would be a first step for the athletes if they were concerned to kind of come in and say, hey, I don't know what to do. I don't know where to go. I just need help. But really, I think explicitly getting to the point, where you've got incoming athletes for the start of the season and you explicitly lay that safe space out, and we kind of acknowledge that this is a part of the culture and a part of what's going on. It's really important. But like I said, I think really just starting the conversation and acknowledging that, it is what it is, that this is not a fun, team building initiation thing that we're going to do this weekend, that this is hazing. And using the words appropriately is going to be a big part of changing the culture. It's my little soapbox, but response to injury and illness, certainly, something that is a deep core value for our athletes. Not going into big depth, but really, thinking about how an athlete's going to respond, right? When you take away, again, you're taking away their identity, you're taking away their team and their peer support, their usual coping strategies through exercise, through sport, through socialization. And then of course, the pressures to return, pressures to perform, in scholastic athletes or elite athletes, is this, affecting their scholarship, affecting their livelihood, affecting their income. So that it can have a far-reaching impact on their life, even just outside of the field. But fear of re-injury can be big. So even as you're, coming back, prolonged recoveries, prolonged return, the fear of losing that all over again can be huge. So, again, offering support, making sure you've got a good sports psychologist who gets it. And I think our role as physicians, and this I think is where it kind of touches us in that orthopedic world as well, is that we've really got to be conscious of the words that we're using, of the way we're describing things, and laying out clear and realistic expectations. An athlete's going to be able to cope with what we offer them if we offer them the appropriate reality. Kind of sugarcoating things, or underlying how long it's going to take to be back, or underlying the recovery is just going to add increased stress as they're taking longer. So really, doing the best you can. And if you're not sure, being upfront that it's still kind of up in the air seems to be really helpful in helping the athletes kind of get through that period of uncertainty and back to kind of their regular life and participation, if that's an option for them. COVID, and I know we're all totally sick of COVID, but I felt obligated to throw this in there. As you can see, even the NCAA is kind of thrown in there, how to deal with COVID and mental health. But I don't think this is so different than thinking about athletes and that mental health impact of injury, illness, and time loss. It's for a lot of athletes over the last year, they missed a big chunk of participation, whether that was, loss of seasons, loss of training, loss of, training with peers, discontinuation of, sports and marathons and triathletes and everything else from your recreational athlete all the way up. You definitely had that time loss and the loss of, the supports and that sort of thing that are impacting them. Just like we were talking about illness and injury, but also the fear of COVID. You're particularly in team sports, a lot of these you're face-to-face, you're indoors, everybody's breathing heavy and exerting, and you've got a lot of close contacts. There's been a lot of fear about COVID transmission, about you then exposing friends or family when you go back home, exposing your campus if you've been off traveling and playing a different team. So there's just a lot of fear that comes with playing sports in the world of COVID right now. And again, I think our role, one, acknowledging that and being able to support the athletes that are concerned, or even those that choose not to play or choose to take a break from sports because of COVID-19 is absolutely reasonable. But, the coping with, friends, family, and peers, I mean, there's virtually nobody left that has been untouched by COVID. And, the loss of loved ones has been widespread, and, supporting young people through that is a whole nother layer of conversation that we're not really going to dive into, but something to really be aware of and, help connect people to resources and support if you're identifying these things. But again, really just making sure that you are the safe space for athletes. Brief takeaways from pharmacology, because I feel like this is one of the things that we always want to know about, and there's very little evidence out there, like, well, how do I just treat it? And if you're going to go down the road of medications, so we said anxiety, your SSRIs and paroxetine, again, kind of the best studied, buspirone plus minus that SSRI, all generally well accepted and well tolerated by athletes. Short-acting medications, really just a no-no, not really helpful and not very well tolerated. Depression, was that fluoxetine or the other SSRIs, your first line. Bupropion may be worth considering, depending on kind of the level of participation and whether that's something that's excluded at their level of competition or by their leagues. ADHD, we really didn't talk about, but again, something that's just common in the high school and college age group. Treatment is just like it is for the general population. Generally with stimulant medication, and it works just like it does in everybody else. Kind of pick and choose and play around and find the thing that seems to be most helpful, with the caveat being that for most athletes, they're going to need a therapeutic exemption once they get beyond high school. So NCAA, WADA, your IOC athletes, things like that are going to need therapeutic exemption if they're able to use it at all. Things that get more complicated than that, a lot of times, thinking about seeking the help of somebody in the psychiatric world. And once you start getting into antipsychotics, mood stabilizing agents, things like that, a lot of us in the primary care side just aren't quite as comfortable managing it long-term. So if you're like me, making sure you've got a good friend who is in that psychiatric side and feels comfortable managing those things, but also keeping that conversation open and making sure that everybody's on board, that this is a team effort, and the communication about side effects, the communication about performance concerns, the expectations of an athlete. Hydration and dehydration can be a huge concern with a lot of the antipsychotic medications or mood stabilizers like lithium. So being particularly cautious in athletes and heavy exertion and heat, so that you're not increasing risk unnecessarily. Side effects like sedation and weight gain, super common and not particularly appreciated by most athletes. So definitely things to consider, and kind of circle back and revisit the treatment plan, both with all of the treating physicians and the athlete. Compliance with these is very important. It's certainly not going to help if you're not taking it. So if side effects are a concern, really trying to address that up front and head it off, so you can address and go to plan B if you need to address a plan B. So general takeaways, screening and prevention really are the core of mental health. Open lines of communication, and you'll see that squashing the stigma of mental health and really just having a conversation is kind of where we're at, that we really just need to start talking about it and accept that this is a widespread problem in this age group. And if you're going to be taking care of high school and college athletes, especially, it's something that you need to be comfortable having the conversation. If you're able to, finding those peer advocates is really helpful, and helping support those peer programs at your campus. When in doubt, if you're prescribing, look at the anti-doping list and really stay vigilant about side effects. Side effects is a big problem in athletic performance, and your athletes are focused on performance. Mental health kind of comes second for a lot of them. So making sure that the performance is not affected is going to help your treatment, your performance, or your compliance where you can. Of course, if you can avoid medication and you've got somebody that's responding well to counseling or cognitive behavioral therapy or mindfulness, yoga, meditation, acupuncture, whatever it is that's working for them, fabulous. And again, great for sports performance, which we're really not talking about today. And my last really kind of soapbox plug is just to be honest and acknowledge what your comfort level is with mental health. It's so broad, and the PCSM world is very, very heterogeneous. We are not exactly the same from one to the other, and even within our individual primary specialties, that spectrum can be very wide. So if you're not comfortable with mental health, if you're not comfortable being that primary care person taking care of depression and anxiety, that's okay. You just need to identify the people around you that are going to be those people, and have a solid team. Don't be afraid to pass the buck if you need to pass the buck. Just know where it's going. So we'll leave that out there. Additional resources. I think these are probably the most common ones that I'll reference. The mental health best practices with the NCAA is fabulous. And they have a bunch of kind of associated, like I said, tools and things like that if you are a team physician that are really helpful in planning and having those conversations with your campus and your team. Mental Health and the Athlete is a book, which I did not link there, but you'll see on the next slide. That IOC assessment tool that I talked about is there. The AMSSM and NATA consensus statements on mental health are both there. And if you're somebody who just likes a little bit of light reading, a lot of these are not necessarily textbooks. That Mental Health and the Athlete is written like a textbook and reads like a textbook. So if you're looking for something that will give you a little bit more nitty gritty about mental health and treating as a physician, that you are the intended audience. The others are a little bit more kind of popular literature. So find your poison and go for it. The mental health best practices, I definitely encourage anyone to read if you're involved in team care or plan to be in the future. And I think that's all we've got. So hopefully we've got still a good time for questions. And like I said, I think the important aspect that we didn't really dive into today is that sports performance, which again is just a huge conversation in and of itself that I don't feel I can give the attention and merit it would deserve in 3 or 4 minutes of that mile high view. But certainly a component of that sports psychology that we want to consider as team docs.
Thank you. That was great. Does anyone have any questions? If so, enter them in the chat. I have a few questions that I've asked my colleagues across the country just to help chime in, young physicians. So one of my colleagues said, or they want to specifically ask, what is your favorite SSRI for high-level athletes? Which I know you mentioned a couple, fluoxetine for depression and paroxetine for anxiety, but in that same conversation with those 2 college team docs, they both said they go with Lexapro first. So I'm just kind of curious, what are your thoughts and why? I know you said side effects, but maybe if you could just list a couple examples.
Yeah, so I'll give you basically my takeaway. presentation wise, what I try and give you is what has evidence. So the fluoxetine, paroxetine are going to be the best actually studied in an athletic population. So if you go into the literature and you start reading and you're looking for evidence, that's where you're going to go. And some of that, I mean, I think is, how much research are you really going to do on pharmacology in athletes surrounding depression when you already know that SSRIs are, approved and effective and we're using them and everything else. So, do you really use fluoxetine and paroxetine? Not necessarily. As if you really don't have a favorite and you're really not sure what to do and you're somebody who likes to, back yourself up with the evidence, or you just happen to like data and you have that PhD and you want to look at statistics, we really like, what the literature says. And that's the literature answer.
Okay.
My I guess less literature-based opinion is that, at the end of the day, SSRI is probably SSRI, and it really just depends on the patient. And, if you've got something that you are drawn to in your regular practice, using what you're familiar with, using what you're comfortable with is probably the right answer. But again, I think just keeping in mind that, your athletes are trying to perform, and, they're not going to really tolerate a lot of, fatigue or poor sleep or heart palpitations and things like that. So if they start having side effects, try something else. But I think at the end of the day, it probably doesn't matter.
Thank you. That was helpful. I don't see any other questions, so I'm going to keep on with mine. I know you touched on both of these next questions I have, but if you have any tips from experience or from your colleagues that the first one is any tips for managing athletes with disordered eating or eating disorders, just experience on what to do, what not to do.
Yeah, I mean, I think it's so hard, and I feel like we should be so much more comfortable with it because it's so prevalent. But I feel like we get like a little bit uncomfortable almost in just starting the conversation. And how do I tell somebody that they have an eating disorder? And I think at the end of the day, the takeaway is they know, right? Like it's not a secret to them that, their BMI is 14 or that, they've only eaten 300 calories today. Like they know. They're very much aware, and the reason that it's so hard to really identify on a survey or a questionnaire or things like that is that they know what not to tell you also. So a lot of times we don't find out until, like I said, that athlete comes in, because they showed up for their PPE this year and all of a sudden they've lost 25 pounds and their BMI is 14 and a half. And somebody said, oh, wait, this doesn't look great. So I think, again, being clear, being concise and being a little bit blunt actually goes over better than you think. And I think that's probably the biggest learning point that I've had through my career is just that don't be afraid to just call it like it is. Most of the athletes are going to appreciate it and just like, okay, yeah, I hear you. I see that. I acknowledge that. And then you can move forward. Kind of trying to drag things out or even to try and get the athlete to kind of come around and say it first is probably not a great use of either of your time. And really addressing the issue so you can get beyond that and move forward is I think the most helpful. For me, I think getting these athletes out of the training room has been most helpful. Again, I feel like that you can kind of take that either way, because in some ways that training room, that campus is their safe space, and you hate to really take them out of the safe space. But putting them in an environment where, like I said, they're a little bit removed seems to kind of facilitate that conversation where they know that you're really just there for them. You're not really there. You're not worried about the coach. You're not worried about their scholarship. You're not worried about their performance on the team. You're really just worried about how they are and what they're doing and what's going on. And then I said, for me, especially, having a set of psychiatrists, psychologists, nutritionists, and a dietitian that are comfortable in this realm is essential. Because you're not going to carry this ball every day. This is somebody that you're going to hand off. This is somebody that needs a lot more intervention than, you know, what most of us as kind of primary care doctors are going to be comfortable with. So I think that's, again, something that a lot of us struggle with, is where I can kind of keep going back to, you know, acknowledge your boundaries, know as far as you're going to take things, and know when to stop. And I think it's a hard line for a lot of us to kind of accept that we don't have to do all of the things. It's okay for us to do that first 20% and then find someone who can take it the rest of the way. So finding your team, and, you know, as a new person, as a fellow, you know, establishing in a new place, you know, spend the time, spend the effort, figure out who those people are, and it will serve you very well coming on the backside.
Thank you. Those were a lot of good tips. Let's see. Anyone else have any questions? I don't see anything in the chat. I have one more if you have time for it. Okay. So this is, I don't think you touched on it. And it can be tough to answer, so I understand if it's a little bit hard. But so how would you approach a dialogue with athletes who present with physical symptoms, such as chest pain, for instance, that they believe to be somatic, but after the workup appears to be negative and all evidence is kind of pointing towards an underlying psych etiology? You know, it's a difficult conversation to have in the athlete. And it can be kind of difficult to explain and convince them. Do you have any advice on how to approach that conversation?
That is a hard question. And I think again, it's one of those things that's difficult in athletes because we don't really know how to deal with it in non-athletes either. But I think athletes particularly are so in touch with every little thing about their body,
right,
that a lot of those manifestations can, you know, only escalate, you know, performance worries or anxiety or everything else, as that kind of perseveration and awareness just escalates. I mean, I think it goes back to kind of how do you address an eating disorder, and, you know, the more blunt and clear, concise, and straightforward you can be, the better. And again, kind of saying, hey, look, you know, especially, you know, is this somebody that, you know, okay, I've got heart pain, I've got chest pain, I've got whatever. We've done a negative workup, we've done all the scary things. Nothing is, you know, organically looking like there is a problem. There's nothing that's looking like there's a risk to you by participating in sport. And I think those are great points to make, but I think it's also really helpful if you can kind of explain that brain connection to an athlete, right? So I mean, everything is controlled by the brain. So just because it's not, you know, a quote unquote organic concern, you know, just because your chest pain is not coming from your heart doesn't mean that it's fake. It doesn't mean that you're not having pain. It doesn't mean that it's quote unquote all in your head. It just means that the way that, you know, your neuroregulation is, you know, messing with you, or, you know, out of sync, or, you know, the way that those concerns have presented themselves are causing these symptoms. And then kind of stepping back and saying, all right, well, if this is, you know, coming from the brain, which seems to go over better to patients than kind of saying, oh, well, it's all in your head, or it's all in your mind, and if we can just change the way that you think about it, like, well, I mean, sort of, but getting in there and kind of, like I said, again, addressing if there are underlying concerns, like are these manifestations of anxiety? Are they manifestations of depression? Is this an eating disorder that's, you know, starting to present in an organic form? Addressing those underlying causes is really helpful. But I think, you know, kind of normalizing that experience of saying this is not made up, I believe you, goes a long way. And saying that, you know, this is a real thing that is caused by something else. You know, even in your non-athletes seems to be appreciated, because I feel like a lot of times, usually by the time they find you, they've been shot down all over the place, and everyone's kind of told them that, you know, they're fine, this isn't happening, there's nothing wrong with you, and, you know, it's all in your head. So for someone to say, yes, this is happening, yes, this is real, no, it's not scary, and yes, we can manage this, is huge. And then, you know, moving forward with, let's say, treating anything underlying, but also getting into those, you know, wellness and mindfulness and breathing exercises and yoga and that sort of stuff is really, really helpful. But yeah, just normalizing that this is a real thing and it's okay, and you're not weird, you're not crazy, this is not an outlier. Very helpful.
Thank you. We have a couple comments. Sam Bogdan said, that's a great point. I really try to normalize mental health issues because everyone feels crazy. And then Lauren Poindexter, our NYU PM&R fellow, said, very helpful, thank you. So I don't have any more questions. I don't see any in the chat, but that was a great lecture, very helpful and applicable to all of our sports medicine and even primary care patients. So thank you for your time today.
Thanks for having me.
And then let me do a shout out for our next lecture. It's going to be next Tuesday, February 16th on complex regional pain syndrome. It looks like I'll be moderating again, and we'll have Julio Martinez Olestrini joining us at 11 a.m. Eastern time. So thank you for tuning in today, and I'll see you next week. Thank you.